Good afternoon. We're going to start our afternoon session on the mitral valve portion of the case. I'd like to, it's my privilege to introduce Dr. Joe Lamelas, who will give us our first talk on minimally invasive mitral valve repair versus replacement, all comers, and how his technique is. As many of us have done, we've all visited Dr. Lamelas and know that his technique is applicable to most of us. He's really refined the procedure, and it's a pleasure to hear it every time we talk about it. Joe Lamelas.
The talk is the one on the Mac. Thank you. It's a privilege to be here to present this afternoon. And I'm going to talk to you about
what's the sequence? I'm not making sure this is
I'd like to talk to you about my approach to minimally invasive mitral surgery, in which I consider it's all comers or all patients, as well as I think all surgeons should eventually be able to do this. These are my disclosures. So this operation is one done or performed through a mini thoracotomy approach. We're not going to talk about any external invasion techniques. And it's either done through a robotic approach, through an endoscopic approach, or through direct vision. And I truly believe the direct vision, minimally invasive approach is one that could be applied to all patients as well as all surgeons. I think this is one in which the surgeon completely controls the entire environment. So if there's any complications at the end of the operation, there's only one person you could blame. So this operation is performed with a single lumen endotracheal tube, a small right lateral mini thoracotomy, all under direct vision, with transincisional cross-clamping. Is a very simplified cardioplegia strategy and the utilization of facilitating and exposure devices. So as I mentioned, there's no double lumen endotracheal tube, no bronchial blocker, one single lumen tube. So throughout the operation, either the lungs are completely inflated or completely deflated. As far as preoperative CT angiography, I don't use this. Obviously, I think that it is important when you're embarking on a minimally invasive program that you do CT angiograms, both of the chest and peripheral, just to get comfortable with, but eventually, especially with mitral cases, I don't think you really need it. This is my femoral platform, which is the axis of choice for the heart-lung machine. An alternative is axillary cannulation, and axillary cannulation in a female patient that has peripheral vascular disease, because all female patients are positioned on the table with the arm over the head. And the last resort is central cannulation. This is definitely doable, although it's technically a little more challenging, and if there is bleeding, obviously it's more difficult to control. So basically, the landmark is right in the middle of the sternum, from the suprasternal notch to the lowest portion of the xiphoid, and then the incision is lateral to the anterior axillary line. It starts right there. In a female patient, as I mentioned, the arm is placed over the head, and we respect the lateral crease of the breast, and again, the mid portion of the sternum. And this coincides with the 4th-5th interspace and with direct vision of the mitral valve. Always utilize a soft tissue retractor, and I like to utilize a rib spreader. There are several cases where we don't need to use it, but I know everybody's talked about pain associated with rib spreading, but if you've ever had a paper cut, there's no rib spreading with a paper cut, and it hurts like hell. And it ends up being a 5 to 6 centimeter incision in just about every patient. So to further simplify the operation, there's no scopes, no balloons, no robots. And I just want to say sorry to some of my ISMIX friends and other robotic guys for the next slide that's going to show up. And so we don't really use robots in these cases. It's all direct vision with direct 3D vision with your own eyes within the incision. This is the pericardial retraction strategy. There's 3 at the level of the inferior vena cava, and these function as the diaphragmatic sutures because they get pulled out through the chest tube incision. So really no need to use a diaphragmatic suture that has a potential of liver injury. 3 in front of the pulmonary veins, 1 at the level of the superior vena cava, and 1 at the top. And then this is the exposure that we usually get with the pericardial retraction. And then we dissect above the right branch of the pulmonary artery, and this is exactly where the cross clamp is placed. And then you can see we deliver 1 dose of a modified Del Nido cardioplegia, which is important. There's a multitude of different choices. The one I use is modified Del Nido, which is 4 parts blood, 1 part crystalloid, 40 MEQs of potassium, and allows me 90 minutes of comfortable operating time without having to redose. And this is usually the exposure, and I extend the incision just lateral to the infrapulmonary veins. I utilize a needle to localize the receptacle on the atrial lift blade, then a 16 French introducer pilloway sheath that goes through the chest wall, and this houses the atrial lift post, which gets connected to the atrial lift blade, as you see here. And then this is the initial visualization, and then the atrial lift post gets placed onto the septum, but we utilize another device called a visor, which gets rolled, and then it gets delivered into the chest. And this is what happens, because that portion of the atrium is very difficult. It gets in the way, and it's very difficult to visualize the entire portion of the annulus. So this gets rolled, placed onto the atrial lift blade, and not only does it retract the right aspect of the atrium, but it also pushes the pump suction out of the way to provide direct visualization of the mitral valve. And this is the visibility that the surgeon has, and just a little bit closer. So there is no doubt when you see this that the visualization of the mitral valve is direct, much more, it's unimpeded and much more anatomical compared to any sternotomy approach. But there is one problem, that it is further away. And because of that, the surgeon needs to be proficient and competent with the use of long-shafted instruments. And these have to be commonplace. You have to even use them on sternotomy cases to reach that comfort level. So I like to say this operation for all patients, all pathologies, and I'll go through a few so you could see. This is obviously a posteral leaflet pathology where we do a little triangle resection. Again, I like to say not all P2s are created equally, so we have to use a variety of techniques. In this technique, you see reunite the edge of P2, utilize one of the limbs of the proline to tack it against the anterior portion of the annulus to provide visibility for the closure of the P2. In this particular case, a full ring. I've gone to using more partial rings in the last year, but in this particular case, it was a full ring. You could also do a combination of resect and respect if you have a very enlarged P2 segment at the end of the operation. As far as the anterior leaflet, I would say 98% of the time it's only a respect strategy that we utilize. We don't resect. We utilize this little device that gets rolled, and then it gets placed into the annulus, which provides very, very significant or improved visibility of the infravalvular apparatus. There's a few things we could do with this, and I'll show you shortly. There's a little video showing exactly how this is placed. And then it pushes the anterior leaflet out of the way, as well as the posteral leaflet. So this is a patient with a flailed A2 segment. I start my operation with placing all of my annular sutures. And then in this particular case, there's one Gore-Tex suture placed through the anterolateral papillary muscle, and then gets placed through the free edge of the anterior leaflet, and with the water test, decide at the end of the operation the height of the leaflet. There's another technique which I like to utilize as well, utilizing a 2-0 Gore-Tex suture and making a very tiny loop, less than a centimeter in length, and then placing multiple cords through this, and then these get placed through the free edge. And the nice thing about this technique is you could take the cords out and replace them at liberty without damage of the papillary muscle. The technique that I like to utilize is this multi-loop technique popularized by Frederick Moore, which is one that I actually, well, this is the loop technique with the multiple loops placed through the small loop. And you can see these are 2 loops on each side, or 2 Gore-Tex sutures on each side, and then finalizing the height of the repair with the saline test. And then all of these sutures are tied with a knot tire. As I like to say, I utilize a 5-knot rule. You don't really need more than 5 knots, and in many cases, you don't need more than 4 knots, and that really does the job. And I think you do need to be proficient utilizing the knot tire. And this is the completed result at the end with this loop technique. For bileaflet pathology, I utilize a combination of respect and resect, or all resect, and you'll see this in a second. This is a patient with a big Barlow's valve with both significant anterior and posterior leaflet prolapse. There's no doubt if there's a central jet by echo with this big Barlow's valve, I will use a very large ring, full ring, and this usually does the trick. But when there's an eccentric jet, I think you have to do a little more work on the leaflet. This is a patient where I did a butterfly technique, resecting the posterior leaflet with 2 triangular resections, both anteriorly and at the base. Reunite these in the middle, and then reattach it posteriorly. And then the anterior leaflet is handled with a multi-loop technique, and this is one that we do on the side table. And these loops are all 25 millimeters to the anterior leaflet. And these are attached at different levels on the anterior leaflet depending upon what the saline test shows at the end. In this particular case, completed with a full ring. You could also use the loop technique for the anterior and posterior leaflet, and you can see there's multiple loops anteriorly and posteriorly, and you can see these are the sutures that are placed that will hold the leaflet in place. And this is a very interesting pathology, which we talked about the other day in patients with systolic anterior motion of the mitral valve with septal hypertrophy. In these cases, I'll take the anterior leaflet down approximately a centimeter past the hinge point. I know this is a little controversial, but I think it is, in my opinion, necessary to go at least half a centimeter to a centimeter past the hinge point. And if you're looking deep into the septum, you can see the fibrosis, which is secondary to the septal hypertrophy. And in these cases, we'll start at 1 o'clock and go to 10 o'clock with an 11 blade, and then go very deep into the ventricle. And you can see this is a 5 centimeter by 1.5 centimeter segment of septum that was resected. Then I utilize a cardiocell patch. I size it approximately half a centimeter to a centimeter larger than the entire annulus, and I suture this to the annulus and the segment of the antral leaflet. And in most cases, I will use a flexible ring or band. I've gone more to using a band lately. If you have severe MAC posteriorly, you don't even need to use a ring in these cases. And this is basically the way it looks. You can see the anterior leaflet coapting with the posterior leaflet, and the body is the cardiocell patch. And this is with the color Doppler. This is a problem that we see as surgeons, which many surgeons say is a true contraindication to a minimally invasive approach. This is a very ominous sign when you see that, very dense calcification extending into the ventricle. In these cases, we resect the antral leaflet. You see this big horseshoe calcification posteriorly. And there's two techniques that we utilize to handle this. One is utilizing a CUSA. You have to grind out all the calcium with a rongeur and then utilize the CUSA to finish it off. And you can see we're left with fat that you can see through the annulus. And obviously, if we don't take care of this, then these patients will have an AV disruption postoperatively. This is a 9 centimeter pericardial patch that we suture to the ventricle. And as you know, you can suture it as deep as you want in the ventricle because the coronary does not lie in the ventricle, the coronary lies in the atrium. And then you finish this off with sutures on the atrial side, and then finalizing it with plegited sutures for the valve. Another interesting technique that we utilized early on is this 8 millimeter Dacron graft that's sutured to the actual valve itself, and then this is sutured in the annulus. This has its sets of problems. I'm not going to go over this, but this is a technique that you can use. The valve sits supraannular above the actual annulus and also within the calcium. The technique that I've gone to lately, but it does have its problems and it does have a very significant learning curve, is placing a sapien valve inverted in the mitral position. This is the first case I did. I used an Amplatzer, which is really not the technique to use. This is a case of a 94-year-old patient that I did a couple weeks ago, where we implanted the valve, and the valve was causing left ventricular outflow tract obstruction because she had a very small left ventricular outflow tract. So I took the valve out and implanted it much higher. The technique that I want to make note of here is the felt strip that encircles the actual sapien valve, because if you don't use this, you could have paravalvular leaks. And most of these patients will have some element of a paravalvular leak. Functional mitral regurgitation is also a problem that can easily be handled through this approach. I like to utilize a ring and sling technique. I use a 4 millimeter Gore-Tex graft that encircles the base of the papillary muscles and bring them as tight as possible together. And then I finish it off with a true-sized annuloplasty ring. I never downsize these patients because I don't want to exchange mitral regurgitation for mitral stenosis. Reoperative mitral surgery could also be done. It's actually a very nice way to do these operations. We do these patients fibrillating. This is a patient that they told us had very mild AI, and you can see this is what the cardiologists call mild AI, and turn into a little more than mild AI, especially when you start manipulating the atrial lift blade. And this is a bad picture, but I want you guys to see what mild AI looks like. So it is very significant. So if you can do it, although it's technically much more challenging. And obviously, tricuspid surgery could also be done concomitantly with these operations. So I think there are other definitive indications that you constantly see in the literature and people saying that should not be done through this approach. Patients that are obese, I believe, are much easier to do through this approach. COPD these patients benefit from a non-sternal splitting operation. A pectus, a little more challenging, but definitely doable. And even patients with bipolar pathology, it says you just need to take a little longer to dissect the lung off of the chest wall. Pulmonary hypertension, I think not opening the sternum, violating the pericardium, not exposing the heart to ambient temperatures or manipulating the heart, I think these patients do much, much better as well as any complex mitral pathology, which I finished showing you. But these two that I did mention are technically more challenging, but doable with sufficient experience. These are some of the postoperative results that you see, some very large patients. And even patients with a tram flap, you respect the incision from the tram flap in order to get into this. And speaking to the plastic surgeons, they say it's safe to do it this way without causing injury. And this is a patient with a double D breast implant, obviously, which would have been very challenging to do through a sternotomy. And then you can see several very large patients. This is a patient, first time sternotomy, first time supposedly minimally invasive mitral, and this is the third operation I did on this patient. Even Superman came to surgery, and also had very good results. So in conclusion, I think that direct visualization simplifies minimally invasive valve surgery. I think the exposure devices that we have today provide the third arm for the surgeon, and they facilitate direct vision, minimally invasive mitral valve surgery, and allows the surgeon to overcome the perceptual complexities associated with inadequate exposure and limited access. If you can't see it, you can't do it, and that's a basic principle in surgery. You need to use whatever you have available to be able to visualize the valve. And I think this is for all surgeons, and it is for all patients, as I finished demonstrating. And as the late Denton Cooley said when he was interviewing me before going to Baylor, he said that, you can't do everything like he used to do. And he said, son, you got to have a gimmick. In other words, you got to do something and do it right and forge forward. And I think we all have to look at this slide carefully because we don't want to be on the left side of the screen. I think we all have to be moving to the right. And that means converting a sternotomy to a lesser invasive approach. And, can you just go back? That was my favorite slide. And I want to invite all of you to join the Save the Sternum Society. Can you go back? That was a good one. Go one. There he goes. I think this is the premise of this meeting, to use a lesser invasive approach where we don't violate the sternum. Thank you.
We're going to go right into the next presentation, just for time constraints here. So, transvalvular mitral bridge implantation results and persistent predictable reduction of ischemic mitral regurgitation at 2 years.
Dear Mr. Chairman, ladies and gentlemen, I would like to present our actually 3 years result of patients with ischemic mitral regurgitation treated by implantation of a mitral bridge. Can you forward the slide for me? So it's moving. Our disclosures. Restrictive ring annuloplasty is a standard treatment for ischemic mitral regurg. It affects the valve by circumferential annular cinching with an indirect septolateral diameter reduction. It has several disadvantages. Some of them are listed in this slide. It has been repeatedly shown that this technique fails to eliminate the mitral regurg, especially in the long-term follow-up, and the recurrence rate can be as high as 60% at 2 years, like in this well-known CTSNet trial. But even with a successful ring restrictive annuloplasty, the valve function is affected. In this work by Julien Magne from Quebec, it has been already in 2008 shown that the dobutamine and exercise echocardiography leads to increase of the mitral gradients, both mean and peak. Mitral bridge is a dynamic silicon nitrile bridge which comes in single piece. It has no moving parts. It's placed transannulary and directly reduces the septolateral diameter of mitral annulus. Thanks to its unique features, it preserves the annular function, the leaflet function, especially in the commissural area, and it promotes the early coaptation. It comes in 5 sizes with 2 anchoring pads for easy surgical placement. Surgical placement is really very easy. we use 2 to 3 overlapping sutures to the base of the anterior leaflet and 2 to 3 horizontal plageted subannular sutures for the posterior leaflet. We use the silastic loops to retract the marginal chordae and to access the subannular area. Then the mitral bridge is implanted with the usual surgical technique. It's lowered in the annulus and the sutures are tied. It eliminates the mitral regurgitation by direct septolateral reduction. But the most important feature of the bridge is the ability to restore the saddle shape of mitral annulus. It actually brings the base of A2 and P2 together and allows the commissures to drop and moves without any restriction. You can appreciate a diastolic expansion of the mitral annulus at the commissural area on this 3D image. We, in Prague, had the opportunity to perform a first-in-human study on a mitral bridge. We included 34 patients with a mitral regurg 3+ or 4+. The mitral repair technique was exclusively a mitral bridge in all patients. 8 patients had the presence of ischemic heart disease and type 3B mitral regurg. We would like to present the data of these 8 patients. There were 3 females. The mean age was just below 70 years. 2 patients had a tricuspid regurg, 3 atrial fibrillation, and 5 history of previous PCI. The ejection fraction was moderately decreased. The left ventricle was slightly dilated. All patients had a 3+ or 4+ mitral regurg. The septolateral diameter was 4 centimeters and the coaptation depth just above 6 millimeters. All procedures were performed through sternotomy. 7 patients had a cabbage, 3 mace, 2 tricuspid repair. The mean mitral bridge size was 24.5, which was significantly smaller than in the rest of the patients in the study. The follow-up period was 40 months. We lost 1 patient 24 months postoperatively for the aortic dissection. At the end of the follow-up period, 1 patient was still on anticoagulation treatment. Other patients were on aspirin. With the mitral bridge implantation, we achieved a significant septolateral diameter reduction of coaptation depth, and we increased the coaptation height. All this effect remained stable over all the follow-up period. It led to elimination of mitral regurg in all patients, and these results again remain stable. Ejection fraction improved and the ventricle gets smaller. We exposed all surviving patients to exercise transthoracic echo, and we showed that there was no increase in gradients, both peak and mean. The valve was able to increase the mitral valve area during the exercise like a native valve. Let me conclude. Mitral bridge effectively eliminates the ischemic mitral regurg by direct non-planar reduction of the septolateral diameter. This effect remains stable over 36 months follow-up period. Mitral bridge doesn't induce functional mitral stenosis in IMR patients. At the moment, we are performing a multi-center post-CMR trial concentrating on more IMR patients, and some transcatheter work is in progress, and we are targeting for a first-in-human transcatheter implantation in 2019. Thank you for your attention.
Great, thank you. In the interest of time, I think we have to move along, and then hopefully we'll have some time at the end of the session because we've had 2 great presentations so far. The next is going to be 2 mini presentations, and if both speakers could come up to the dais here. So the first one, 3D endoscopic versus direct vision approach in minimally invasive mitral valve surgery by Dr. Mayer from the German Heart Center in Berlin and colleagues. And the next one would be the 3-port totally endoscopic mitral valve surgery propensity match comparison and that'll be by Dr. Takuro from the Japanese Red Cross Hospital. So, please.
Dear Chairman, dear colleagues, thank you very much. Within the next minutes, I'm going to present you the results of our comparative study of the 3D total endoscopic approach versus the direct vision approach in minimal invasive mitral valve surgery. Study design. So this is a single-center retrospective cohort study. We performed from 2014 to 2017 477 mitral valve surgeries. We excluded minimal invasive isolated tricuspid valve surgeries. We formed two groups. First, the 3D fully endoscopic approach group, consisting of the non-rib spreading approach, of a perialveolar incision in male patients, and endoclamping. And the classical group, which consists of 2D video-assisted approach, mainly with direct vision, and Chitwood clamping. To address missing data bias, we performed 5-fold multiple imputation, and to address confounding, we performed 1-to-1 propensity score matching. This leads to a study cohort of 120 well-matched pairs. As you can see in this figure, the preoperative baseline covariates were well balanced and there were no significant difference anymore visible. Let's go to the results. The 3D total endoscopic approach with no rib spreading was feasible in all cases. We did not observe any specific endoballoon associated complications, and in both groups, valve repair rates were similar. 98% in the direct vision group and 100% in the 3D total endoscopic group. Survival was also similar. Of course, we also looked at different outcomes such as new stroke, postoperative delirium, the necessity of rethoracotomy, the new myocardial infarction postoperatively or low cardiac output syndrome, and several others. The main message is there were no significant differences, except of procedural times. We observed a significant and substantial difference in operative time, cardiopulmonary bypass time, and X-clamping time, which were all higher in the 3D total endoscopic group. As you can see here is an example. We observed a median difference of 8 minutes in the 3D total endoscopic group. Let me conclude. The 3D total endoscopic setup utilizing endoaortic clamping provided excellent valve visualization, enabled a non-rib spreading access in all cases, but was slightly more time-consuming. However, we did not observe any difference in regard to procedure safety and quality of mitral valve repair. With that, thank you very much.
And Dr. Takuro, and we may be caught up and have one or two very brief questions after your presentation.
Yes.
Specific to your two, and then.
Okay, let's start. We began to perform minimally invasive mitral valve surgery in 2010. The method of 3-port total endoscopic mitral valve surgery was published in the European Journal of Cardiothoracic Surgery in 2017. In short, 2.5 main incision at the fourth or fifth intercostal space, and left working port at the second or third intercostal space, and 3D endoscope is inserted at the fourth intercostal space. This illustration shows the setting. The main aim of this study was to compare the safety and invasiveness of 3-port total endoscopic mitral valve surgery, MVS, with those of conventional mitral valve surgery, CMVS. Between January 2009 and May 2018, 823 patients had undergone mitral valve surgery in our hospital. We excluded the concomitant surgeries with aortic valve surgeries, coronary bypass, and aortic surgeries. Then we enrolled the 372 patients as a MVS group and 147 patients as a CMVS group. Propensity matching between these two groups generated 142 matched pairs. Primary endpoints were major adverse cardiac and cerebrovascular events, and the secondary endpoints were postoperative length of ICU and hospital stay. This slide demonstrates the results. After propensity matching, there were no longer any significant differences in background. And the main clinical outcomes on these two groups were presented in this table. The major adverse cardiac and cerebrovascular events were significantly lower in MVS group. The rate of combined surgeries was higher in CMVS. Surgery time was almost the same in these two groups, but CPB time and aorta cross-clamp time were significantly longer in MVS. And the length of ICU stay and post-operative hospital stay were considerably reduced in MVS group. The blood transfusion unit per patient was significantly lower in MVS. In conclusion, 3-port total endoscopic mitral valve surgery is safer, and we can expect a quicker recovery, and the early outcomes are excellent. And of course, this is cosmetically superior to the conventional surgery, and we can share the better view of the field, and this is educationally beneficial for the trainee surgeons. Thank you for listening.
Okay, for the sake of time, we have to move on. I'd like to invite the next speaker, Dr. Doolabh from Turkey, to present minimally invasive video-assisted concomitant multiple valve surgery through right anterior mini thoracotomy.
Good afternoon, dear Chairman and dear colleagues. I would like to share our experience about minimally invasive multiple valve surgery. All as you know, median sternotomy is a standard care for the cardiac surgery for years. But in the past decade, minimally invasive approach had also gained popularity in every part of surgery as well as in the cardiac surgery. On the other hand, performing minimally invasive approach for all kinds of surgery, cardiac surgery, are not always possible, especially for the multiple valve surgery. With the help of the increasing experience and learning curve in this area, helped us performing complex surgical procedure. The parallel of the evolution of some technological modalities, such as sutureless valve, has made minimally invasive valvular surgery safer and more easier. We identified the 15 patients with severe aortic stenosis who underwent SUAVR with concomitant mitral valve surgery. A modified Cox-Maze procedure was performed in the atrial fibrillation using the cryothermia. Preoperative cardiac CT evaluation is very important steps in the minimally invasive valvular surgery, because it helps the surgeon to measure the aortocomitral distance easily, decide what kind of the valves will preferred, and from which intercostal space will be used for applying multiple valve surgery. We published some technical details about importance of the aortocomitral distances in patients who had a SUAVR with the concomitant mitral valve surgery. We believe that aortocomitral distances has a paramount importance in SUAVR and concomitant mitral valve surgery. If the patient has a less than aortocomitral distance less than the 5 millimeter, surgery can be difficult. So we measured the aortocomitral distance in all patients with using CT images, and also 3D reconstruction carto images allowed to multi-angle visualization of the aortocomitral distance anatomy. I would like to show some video record. We used the peripheral cannulation via femoral artery, femoral vein, and interjugular vein with T guidances. We enter the thorax at the level of the third intercostal space. After the past, the adipose tissue and the muscle and then deflate the right lung, soft tissue retractor placed, and then open the pericardium at the level of the 2 centimeter above the phrenic nerve. Sheathwood clamp used, and custodial cardioplegia gave. And then aorta opened transversely and inserted 3 commissural traction suture for better surgical visualization, and then excise the aortic valve, and then we put the 3 guiding suture for the Perceval implantation. And then we skip the left atrium for the performing the Cox-Maze procedure using the cryoablation. As you see, very calcified anterior and posterior leaflet. We preserved the posterior leaflet at least using the implantation of the mitral valve. And we put the U-matrix sutures. And we performed the, measure the valve size. And then Hancock 2 biological mitral valve was implanted. We used Cornat devices for tying sutures. And then we skip the aortic position for the Perceval implantation. There is a tricky point. We prefer putting the guiding sutures before mitral valve implantation because in some cases non-coronary cusp can be retracted inferiorly with the implanted mitral valve and can be difficult to find neither of it. We implanted the Perceval and then we checked the valves with the water test and closed the aorta. Perioperative T evaluation showed that no significant gradient at the level of the left ventricular outflow tract, and the maximal aortic valve gradient was about 20 millimeter mercury. This is the table summarized that our baseline characteristic. They all had problems in aortic, mitral, and or tricuspid valves. 11 of patients also had atrial fibrillation. Mean aortic valve gradient was 60 millimeter mercury. Nearly all of the patients had severe mitral stenosis, except 3 patients had severe mitral regurgitation. Mean articomitral distance is 6.8 millimeter. This is the periprocedural characteristic. As you see, even though all surgery, only one patient had a problem during the aortic valve replacement due to the supraannular disposition, and we redeployed anti-valve implantation. We solved this problem. This is the X-ray and the CT images. You can see the Perceval and the biologic mitral valve and the tricuspid valve. This is the early postoperative picture. As a conclusion, the study showed that the implantation of the multiple valve concomitantly through a right anterior mini thoracotomy is technically feasible and safe procedure in selected patients with acceptable surgical outcomes. On the other hand, Perceval proved to be an excellent solution for the patients requiring concomitant procedure. Thank you for your attention.
Our next presentation would be Dr. Zhen Zhang from China, and it's totally video-assisted thoracoscopic mitral valve replacement, a comparative study of 3D high-definition and 2D high-definition video systems.
Well, as we know, the 3D image technology is now everywhere in our daily life. It has already shown its benefits over the traditional 2D image system. As cardiac surgeons, we simply want to know, do we have such advantages in endoscopic cardiac surgery? The picture on the left shows us the generation of the stereo vision, We can get the information about shape, color, or brightness with our single eye, but for the perception of depth, we have to use both of our eyes to collaborate. That is why we have 2 cameras on the head of the 3D thoracoscope, while we have only 1 on the 3D thoracoscope. As we do in the cinema, we have to wear polarized glasses when we perform 3D endoscopic surgery. In our institute, we started to perform 3D endoscopic cardiac surgery since 2013. By now, we have accomplished about 600 cases, which is the largest group in China. Is 3D better than 2D in endoscopic cardiac surgery? To answer this question, we perform a retrospective study from 2013 to 2017. All patients underwent single mitral valve replacement using either 3D or 2D image system were included. Each patient was operated by the same surgeon using the same surgical technique. During the procedure, we use unilateral lung ventilation with peripheral cardiopulmonary bypass. There are 4 surgical incisions in total. The main incision is about 3 centimeters in length. There are 43 patients in the 3D group and 47 patients in the 2D group. We can see that the use of 3D vision can significantly reduce the aortic cross-clamp time by 7 minutes, which is about 10%. In the same time, there is no significant difference between the postoperative ventilation duration, SICU stay, hospital stay, major complications, or deaths between the 2 groups. In our experience, when performing mitral valve replacement, the 3D vision can provide us with valuable depth information about the left atrium or left ventricle. So we feel more confident when resecting the diseased leaflet or placing sutures around the annulus. We found that less time was wasted with repetitive or correctional moves compared to the 2D image system with the help of the stereo vision. In addition, the anti-fog feature of the 3D camera head definitely reduced the time for lens cleaning during the surgery. In conclusion, we think with the help of the 3D vision, it can provide us with better surgical experience with the same operative safety in mitral valve replacement. We think 3D vision is a promising technology that will be widespread in the field of endoscopic cardiac surgery in the future. Thank you.
In the interest of time, we're going to move forward. The next talk is 3D thoracoscopy correlates with shorter cross-clamp times among patients undergoing perioral minimally invasive mitral valve repair, and it's by Dr. Somziski.
Thank you for the opportunity to present our study during this conference. I represent Central Clinical Hospital from the Ministry of Interior from Warsaw in Poland. The presentation is and study is also about problem with visualization. We found some difficult maneuvers into the thoracoscopy. Maneuvers such as measuring of chordas, implantation of the PTFE loops, finding loops in the ventricular chamber, leaflet catching, and extremely annoying proper stitch cutting. We found these problems when we switched to the totally thoracoscopic perioral approach. Subjectively, we found much easier these maneuvers in 3D thoracoscopy. So we simply ask if there is any differences between 2D and 3D thoracoscopy. We divided patients in these 2 groups. The groups did not differ in terms of preoperative data and demographic data. In the results, we found that mitral valve plasty with ring and PTFE loop implantation correlates with shorter cross-clamp time and also shorter total extracorporeal circulation time. However, this correlation was not found in isolated ring implantation. We checked if there is any correlation between numbers of PTFE loop implantation, and the correlation was negative. The other postoperative data were comparable between groups. We also didn't notice conversion from minimally invasive approach to sternotomy or conversion from totally thoracoscopic approach to mini thoracotomy. In hospital mortality was also comparable. In conclusion, 3D thoracoscopic technology reduced cross-clamp time and cardiopulmonary bypass time in complex mitral valve repair with PTFE loop implantation if we compare it with 2D thoracoscopic approach. The reduction of intraoperative time did not influence on early postoperative outcomes. Simple mitral ring implantation does not correlate with significant cross-clamp time reduction in totally thoracoscopic perialar approach. Actually, it seems to be logical because we do not perform complicated maneuvers on papillary muscle leaflets. And finally, 3D thoracoscopy seems to be a helpful device, especially in a complex valve repair. It's not just a toy. Thank you for your attention.
Okay, let's move on. I'd like to invite Dr. Poffo to present 3D-enabled totally endoscopic surgery in training of mitral valve repair. He's from Innsbruck, Austria.
Dear Chairman, ladies and gentlemen, welcome to this talk about training in mitral valve repair. Teaching mitral valve repair traditionally is rather difficult as surgeon and assistant have different views in sternotomy or partial sternotomy. So we hypothesized that endoscopic imaging gives improved view as all surgeons have the same view. And we analyzed the impact of 3D totally endoscopic mitral valve repair on training and compared it with our 2D cohort. During the last decade, more than 1,100 procedures, minimally invasively, were done. During the last time, predominantly totally endoscopic ones. We analyzed 536 patients with minimal invasive MV procedures. All of them were done with groin vessel cannulation, transthoracic chitral clamp, and all available techniques were applied from simple ring annuloplasty over prolapse up to Ballot's disease and active endocarditis. The 2D group consisted of 345 patients with a thoracotomy with rib spreader and always direct vision, as there are very few surgeons worldwide who can do totally endoscopic procedure with 2D systems. The 3D group consisted of 191 patients. In male, we did a periareolar incision, and female a submammary incision, and this was always a totally endoscopic procedure. Teaching was accomplished in 17% in the 2D group and in more than half of the patients in the 3D group, nevertheless resulting in mitral valve repair rates of above 90%. The cross-clamp time was even shorter in the 3D teaching group, and other outcome parameters like conversion to MV replacement was low in the 3D group, as well teaching as non-teaching. We had to convert to sternotomy a bit more often in the 3D teaching group. On the other hand, the revision need for bleeding was exceptionally low. ECMO was necessary in a few patients in the 3D group. Fortunately, we had zero mortality in the teaching group, and the repair rates, the success rates were really good with 99% with no MR at time of discharge. So we conclude that the surgical aspects and operating times are comparable with all these groups. The mortality is low, zero in the teaching group. the repair rates are excellent, and we conclude that a 3D video is an excellent tool for teaching and training all the aspects of mitral valve surgery. Thanks a lot.
Thank you. So the next talk is triport chest thoracoscopic cardiac surgery for cardiac myxoma resection in a perfused beating heart by Dr. Ma. I have one question. Now that we're on this previous topic, and since Dr. Poffo has a significant experience, it seems like if you do the operation through incision around the nipple, that it's almost mandatory to utilize a scope because you're much more medial, so your visibility is probably limited.
Yeah, especially in men. You know, in women with large breasts, you can move the breast around and find a nice straight way to the mitral valve. I think as medial the areola is, more you have to rely on the video assistance.
Okay. Ladies and gentlemen, good afternoon. I introduce a tripod chest thoracoscopic cardiac surgery for my eczema. Is the operations performed through 3 ports, right chest. Is the case clinical data is the clinical diagnosis is left atrial eczema. Is the video is the card pericardium. Is insert the left trim the adjoining tuber. It direct cut the groove. It position left trim the my expert is egg posing. Resect the particle of my eczema. The pour of and then the water which the left tree. This right chest to carbon dioxide. In the suture, the incision. This operation is simple, and the procedure is the faster. And the clinical result is excellent. The operation time, CPP time, and the ICU time is the total shorter. So the operation is simple and easy.
Yeah.
We're going to move on and then go ahead and do all the questions at the end. And the final talk is from Dr. Shibata from Osaka, Japan, minimally invasive mitral and tricuspid repair in Situs, Inversus, Totalis.
Thank you very much. I'm very happy to share my experiences with a rare case. Please start. Yeah, so minimally invasive surgery, so mitral tricuspid repair for Situs Inversus patients. A patient is 17 years male, the Situs Inversus Totalis and atrial fibrillation. He has a severe mitral MR and TR with enlarged LA and LA. And the mitral severe MR due to A3 prolapse, enlarged mitral annulus. As you can see, all organs is mirror imaged. Unfortunately, no other abnormality was detected. The echocardiography shows this loss of coaptation and the severe MR. As you can see, the mirror image mitral valve, so left side is A3 and A3 prolapse you showed. The operation was performed with mini left thoracotomy, ascending aortic cannulation due to some problem of the peripheral arteries. So mitral valve repair with loop technique and video-2 ring implantation and TAP with flexible total rings. The patient is Situs Inversus. So left side is A3. You can see the elongated corridor in the A3 prolapse. First, I put an ink dot to identify the prolapse area, and I measure the reference length of corridor length. And on the backside table, we make the loop set with the pre-measure length. The loop set was fixed to the posterior papillary muscle because of a mirror image, and fixed not pusher. The loop set was made by the CB4 Gore-Tex suture. The loop was fixed to the leaflet edge fibroprolene with double passing fashion. And the second loop was fixed as the same manner. Then the annuloplasty stitch was placed. As you know, the right side is the aortic side, so we have to take care not to injure the left coronary circumflex artery in the right side. The mitral annulus is so enlarged. The 30 millimeter video-2 ring was implanted. The saline test revealed good result. Then we move to the tricuspid. First, we identify the three commissures. The tricuspid annulus was extremely enlarged. We put 3 stitches at each commissures. And then an additional stitch on the septal annulus away from the AV node system. If we use a 3D-shaped tricuspid rigid ring inside out, the figure of the ring is unmatched to the mirror image tricuspid valves because of the Situs Inversus. So the flexible total ring is fixed with a running suture. We didn't put a stitch at the septal side, septal reflex annulus near the AV node system. The threading test is good. The postoperative echo shows a good result with a tiny regurgitation of the mitral valve. And he is doing well after 2 years of operation. Thank you very much for your attention.
So we'll take questions from the audience.
Joe, while we're waiting for somebody to come up, can you comment on your technique for doing these operations in a redo setting? As you so nicely showed what AI looks like, obviously you're not using a cross clamp. How do you manage the operation with?
Right. I do these operations with the heart fibrillating. I cool the patient till they fibrillate, and then I do the operation fibrillate. I like the beating heart technique. I know Dr. Glauber showed us yesterday his technique where he did rapid pacing, and then he inserted a vent in the left ventricle, and that seemed to work. And that's definitely a good alternative. I've not done that because I think that possibly the risk of stroke will be a little higher. So I cool them down, even if I've had some patients which I have to cool down to 20 before they begin to fibrillate. I think some of these people are polar bears, but because they really, you have to cool them down quite significantly. But anyhow, I do that on the majority of cases. If the patient does not have any proximal anastomoses, then I will try to cross-clamp the aorta because I do think it's easier to do the operation. If you have grafts on the aorta, that becomes technically challenging, and you have to get as high up as possible. The main thing you have to worry about when you cross-clamp the aorta on a redo patient is, well, one thing I'm very particular about is going underneath the aorta above the right branch of the pulmonary artery. But the big problem is to make, or the most significant thing is to make sure you dissect the pulmonary artery off of the pericardium. So it's not attached, because in some cases, I had one case where I placed the cross clamp and I put a hole in the pulmonary artery. And technically, it's extremely challenging to fix. So you have to keep that in mind.
As somebody mentioned today, I'm impatient as well. Sometimes I utilize a pacing swan, because that way you don't have to cool for so long.
Yeah.
And what I find with these hearts, they're so rigid. As you elevate them in the redo setting, you can make more of that AI. So I agree with you to cross clamp if you can.
Yeah, the trick to that is to obviously move it around different positions. Believe it or not, if you advance the atrial lift further in, it can take care of the bleeding. As far as the pacing pacemaker, I place a transvenous pacer on all the minimally invasive redo aortic valves. On the mitrals, I tend not to. Most of the time, I can get to the inferior wall. There are cases where I wish I would have had it, but for the most part, I don't. And we talked yesterday about a technique that I think is very, very good to use in patients that need redo isolated tricuspid valve surgery, where you just place a cannula directly from the femoral vein into the supravena cava. You open the right atrium with the heart beating, and you don't even need to snare the cavas, and you can do the tricuspid valve very easily. And you obviously use the pericardium as your reinforcement layer to close the right atrium at the end. Yes, sir.
Simon Moten, Melbourne, Australia. Could I ask a question to the presenter for the multiple valve surgery, Dr. Doolabh? When you're placing the mitral valve, do you make any changes to the way that you either size the mitral valve or where you place your annular sutures when you were thinking about putting in the Percival afterwards?
Dr. Doolabh?
He's done a run. We'll leave that question.
Well, just, I don't have experience with double valve, with a sutureless valve. I know you have a significant amount. I've done probably over 300 double valves, aortic and mitral, through this approach. But I was going to ask him the same question. He has a series of 14 cases through an anterior thoracotomy. That was my early experience. I used to do that years ago, but I found that doing it through a more lateral approach, almost like a mitral approach, placing the arm over the head on all patients for aortic and mitral surgery, you have excellent exposure to the mitral valve, which is what I think is the most important, that you do have problems seeing the non-coronary portion of the aortic annulus. So that's the most challenging part, but obviously if you want to do any complex mitral surgery, I think the arm needs to go over the head, because this anterior approach does have great exposure to the aortic, but not always the best for the mitral. Great. Any other questions? I guess everybody's ready to go to the reception or the poster presentation.
Okay.
Well, I guess this concludes this portion of the session. The meeting.